Everybody, we come to this session, competitive session on Pediatric 1, on Pediatric Ophthalmology, and we have, who is the first speaker?
The first speaker is Dr. Ashutosh Kumar Gupta. He'll be talking a paper on posterior zone 2 ROP, spectrum of disease and comparative outcome of intravitreal ranibizumab and Leo.
Good morning, everyone. My topic is posterior zone 2 ROP, its morphological spectrum and treatment outcome. The term posterior zone ROP was introduced in ICROP3 in 2021. It's the region that begins between the margin between zone 1 and zone 2, and its 2 disc diameter. It indicates potentially more worrisome disease. The morphology of ROP in posterior zone 2 is have not been well reported. So the purpose of this study was to report the demography, morphological spectrum, and outcome after laser treatment or intravitreal ranibizumab. It was an ambidextrous interventional case series. The study period was between July 22 and December 23, and the eyes with posterior zone 2 ROP were included. The following information were recorded from the clinical record, which included demographic detail like birth weight, period of gestation, and neonatal complications like respiratory distress, duration of oxygen supplement. All the infants were examined with indirect ophthalmoscopy, and red cam fundus photogram was done in most of the patients. The treatment was either done with 532 green laser or intravitreal ranibizumab. The dose was 0.25 milligram in 0.025 ml. It was taken as a favorable outcome when there was a complete disease regression, or unfavorable when there was greater than 3 clock hour of 480 RD or stage 4B or 5. Around 64 eyes of 33 infants were included in the study. The mean birth weight was 1400 grams, ranging from 960 and 2250 grams. The mean gestational age was 30 weeks. All the patients were outborn, that is, they were not from our centers, they were referred from outside. And 6 babies were twins. The mean oxygen supply was roughly around 10 days, and there was 11 infants which give history of ventilation support, 13 infants sepsis, 7 infants blood transfusion, and around 48.49 patients gave history, there was history of respiratory distress. So of 64 eyes, 11 eyes were treated with the intravitreal ranibizumab, and 46 eyes, that is 71.87, were treated with the laser. The eyes which were treated with intravitreal ranibizumab, there was no adverse event noted. Of the total eyes, 11 eyes, there was regression of the acute phase of the ROP post-intravitreal injections. Later on, 7 eyes, they were due to reactivation, laser was done. The morphological features which were present in zone 2 was divided into 3. That was stage ROP, which was present around in 56% cases, and rest half was equally between hybrid ROP and AROP. The most common morphological feature was ill-defined ridge, which was in 25% eyes, followed by large vascular loop, small vascular, well-defined ridges, and pre-retinal hemorrhage was present in 14 eyes. There are few the photographs. This is red cam photograph of the left eye, AROP with large vascular loops and pre-retinal hemorrhage. This is another photograph of AROP, zone 2 posterior with large vascular loops. This is red cam photograph of the right eye, which is showing large vascular loops. This is another example of hybrid ROP, which is showing large vascular loops and ill-defined ridge. Same, another red cam photograph, which is showing ill-defined ridge in a hybrid ROP. This is another example of red cam photograph, which is showing well-defined ridges. This is another photograph, well-defined ridges. This is left eye red cam photograph of hybrid ROP in zone 2 posterior, which is showing mat-like epiretinal progression, pre-retinal hemorrhage, and flat-shaped NV. Similar photograph. As I have already discussed, most 56% eyes have stage ROP, and rest were AROP and hybrid ROP in 22% cases. This is for example 1, where a 32 preterm male with hybrid ROP in posterior zone 2, he was treated with laser. Post-laser, there was a favorable outcome. This is another photograph with stage 3 ROP, laser photocoagulation was done with favorable outcome. This is 29-week preterm with AROP, intravitreal ranibizumab was given, and there was resolution of acute phase. After that, after 10 weeks, there was reactivation for which laser was done. This is another photograph of AROP where laser was performed and there was complete favorable outcome was there. So in my study, there were complete regression in 100% of the cases. Cycloplegic refraction was done 1 year of the treatment, which shows a mean spherical equivalent refraction of 0.025 diopter with maximum between -2 and +2.5. Thank you.
So, how do you decide which case to do injection and which case to do laser?
Sir, we give the parents. We discuss the parents about both the options of treatment. For injection, we have told them they require more follow-up as compared to laser, which require less follow-up. After that, we have always we have told them about the pros and cons of both the procedures. About laser, which is a permanent procedure, for anti-VEGF, they require close follow-up.
How
So
long
based
follow-up
on
you had? Sorry, how long follow-up you had? I think you.
sir,
follow-up
1 year follow-up, sir.
1 year.
Yes, sir.
You had recurrence in almost 22 cases.
No, ma'am. After we have
After the
we have
injections.
injected in 11 eyes, there was reactivation in all the eyes.
In all the eyes. So
Yes,
we had to
ma'am.
do lasers in all of
Yes,
them?
ma'am. Laser was done, and the average recurrence was 10 weeks.
Okay, okay.
And you didn't find higher incidence of myopia in these children?
Yes, sir. Sir, the myopia was the most of them are -2.5 and +2, most of them. Otherwise, the maximum was -4.5 diopter. But it was in very few cases. Though in the literature it has been found most of the cases who are treated with laser, they have got high myopia as compared to those who have given intravitreal anti-VEGF. But in our cases, the average was roughly, it was not a high incidence of myopia. But the limitation was that it was just a 1 year follow-up.
Yeah.
We
so
have done,
follow-up is
yes,
very less.
yes, ma'am,
So
because
you
we
cannot
are,
still comment on the
Yes,
myopia
ma'am.
progression which is happening in these
yes,
cases.
ma'am.
Yes.
Ma'am. Thank you, sir.
Thank you. Nice presentation. Thank you. Next,
We are
Dr.
taking in Dr. Aditya first. Probably he has another session. So sorry for that. So Dr. Aditya will be presenting his talk, his paper on. Yes, Dr. Aditya. Yeah, long-term outcomes of implanting EDOF IOLs in pediatric cataract patients.
Thank you so much, ma'am. Sorry for barging in. My free paper today is something very unique. It's about long-term outcomes of implanting EDOF IOLs. Just one second. Yeah. So this is the study that we did. EDOF IOLs have been gaining a lot of popularity, especially the advanced monofocals, and in adult cases, they've given repeatable results. So the natural thought came to us is why not imply the similar IOLs in pediatric age groups, because this is basically the main problem. There's a huge gap. The significance of our study lies in the fact that there's no or none research absolutely done for EDOF IOLs in pediatric age groups. There's a big transition where multifocals have been studied and monofocals have been studied, but nothing in between. And of course, we always look for immediate results when we talk about pediatric age group, because you're not only doing a cataract surgery, you're also looking at amblyopia, and that is the main evil that you want to fight. And it actually has real impact through a comparative study, because this is probably one of the only studies which are there at the moment, talking about EDOF IOLs in pediatric age group. Implications of clinical practice, of course, if this becomes in a higher number, as another study or a cross-sectional study is done, this will actually have a very positive implication in all our practices. And of course, quality of life enhancement, that's exactly why we do any sort of surgery in pediatric age groups, is because we want them to see better and live better and learn better. So methodology, this was a single center retrospective observational study, and we needed to compare different types of outcomes when we put a EDOF IOL, the less damaging ones, of course, and enhanced monofocals versus traditional spherical IOLs in pediatric age group. We divided into 3 groups. Group 1 was basically more than 10 years of age, where we were more generous with the choice of EDOF IOL. In group 2, we had about 11 young children, and this was between 1 to 10, where we used the advanced monofocal or enhanced monofocals without the rings. And group 3 was the 14 eyes, which we did with traditional spherical IOLs. And there was basically an exclusion criteria of any other sort of ocular condition, like a retinal detachment or anything else that would have made it less perfect. So these were the implants we chose, no financial interest at all. Methodology, again, retrospective review. We did all ethical considerations, took all consents, got all approvals, and did everything in accordance with Declaration of Helsinki. And the basic challenge we had, since it was retrospective, there was limited data, or the right data was not there in certain cases, and those were excluded accordingly. So now this is what the baseline looked like. Most of the group 1, group 2, group 3 that we saw had similar 20 by 200 uncorrected visual acuity was the average. And you can see in post-op outcomes, the significant improvement happened post-cataract surgery in most of the cases. But as time went, most of the 85% of the EDOF IOLs actually achieved 20/40 or better, with or without the need of corrective glasses. And enhanced monofocals, about 75% actually end up with 20/40. And traditional, of course, 60% of them achieved, and of course required glasses to get better vision. So statistical analysis, we got to know that the traditional IOLs versus the EDOF IOLs in the older age group, of course the EDOF IOLs did much better as far as being uncorrected, as well as with minimal correction. And the group 2 showed a lot of better improvement when we were talking as compared to the traditional ones, when we had a minimal glass in front of the eye. But between 1 and 2, there was not much significance statistically. So implication is that it may be a good idea to choose these in an older age group, but still it's a gray zone because the data is very limited. This is something that I thought was very important, is the amblyopia management success. And we saw that group 1 and group 2, that is EDOF IOLs and enhanced monofocals, both had a better recovery as far as amblyopia was concerned as compared to traditional IOLs, which required the standard amblyopia management, which ended up being a slow progressor or slow recoverer as compared to the group 1 and group 2. So the rates went as high as 90%, could be because they were older children, so it was easier to get the amblyopia success in these cases. Spectacle dependence, also the rate of spectacle dependence was much lower when we talked about EDOF or advanced monofocals as compared to the traditional IOLs, and they required a heavier glass depending on the age again. So in discussion, it's actually filling a big void, and their superior outcomes. It is something that there's a big call for longitudinal studies, and there's a lot of future talks which need to be encompassing these set of IOLs. What I like to say is that what seems like the right IOL today may not be so in the future, and that goes both ways. So it doesn't mean that this is the right one, doesn't mean that's the right one, because the child will live long. Thank you so much.
And Dr. Aditya,
Sorry. Okay.
what are the disadvantages, any disadvantages in your study?
So the number of patients were very less, so you can't draw a conclusion at all at this moment. But again, in today's world, I think it has to be a cross-sectional study with multiple centers to actually make a difference, because everybody needs to pull in their data. So it's more of a cry of, if anybody else is doing, we'll collaborate our data and make a bigger study. So the biggest disadvantage is limitation of what data we could collect. We couldn't find out the side effects of ring-structured EDOF IOLs like glare and halos in these children, because they didn't complain much as far as that is concerned. But considering that the adults complain less about this, with these IOLs, we've taken that into non-comparative data altogether.
There are issues of, I think in children, they could have amblyopia also. You have to see what is younger and what is
Correct,
older.
sir.
You did not.
Correct. That's why we
elaborate on
chose.
that, because younger would be a child who is 2-year-old, a child who is 6-year-old. They are also undergoing emetropization.
Yes.
Child who is 10-year-old. They are different set of situations.
Correct.
And,
So little biased data is also there when we talk about the choice of age group, because we've chosen EDOFs in older age group, and we've not specified the traditional spherical IOLs. The age group varied.
And we need follow-up also.
Follow-up also.
Then
More
it's a
inclusive
very-
data would actually make a
so
bigger
it is a
study.
very
Yeah.
difficult.
Nice.
So as you've yourself pointed out, there was a big confounding bias in this because the age group was different for the three groups we had.
Yeah, ma'am.
And so that is, obviously, this
I think
comparison
that
should have
comes
been in the
with-
same group.
yeah.
And secondly, the thing is, like, you've taken older age groups, obviously, they would have denser amblyopia
denser
if they
amblyopia.
had congenital cataract.
Correct. But they actually did very well. That was the surprising part with EDOF IOLs. The older age group with EDOFs actually
So
did
see,
well.
it means then they were not
But
congenital
again-
cataracts, they would have been development acquired cataracts.
Correct, correct.
Okay,
So again,
then
it's very
congenital
difficult to
cataract
point.
Not having amblyopia at
Yeah.
that age group, it's unlikely, if it is a
Absolutely.
significant, visually significant
Absolutely.
cataract.
Thank you.
Yeah.
No, no. Thank you so much.
Yeah, so basically your numbers are very small, no? So saying
Correct.
80%, 75% in very small numbers and saying that is significant is difficult to say. It could just be a difference of one case and
Absolutely.
it could show 5, 7, 10% difference.
But I think that comes with the type of implant.
so I think in the
I
slides-
don't know anybody who's
Yeah,
putting
so that's
large
fine.
numbers with
But
these
I think in the
implants.
slides it's a good idea to put the
Retrospective
N also.
Yeah,
with the
it's
percentage that
retrospective
mix.
study.
It's a retrospective study, sir.
Sure?
No, no, you
Okay.
can't. No,
Sorry.
it's not allowed.
We need to mention the etiology in this to be able to look at the results.
Yeah. Etiology, unilateral, bilateral, that will also
yeah,
make a
that's a-
difference. Yeah, a lot of, it's a big, huge area, I think, so it's a, thank you.
Can we now invite upon the second speaker? I mean, let's go back to the order. It's Dr. Seema Kumari, is she there? So, Dr. Seema Kumari will be talking about a study to assess ocular findings in beta thalassemia major in pediatric population in East Singbum.
A very good morning to one and all. I'll be presenting a study to assess the ocular findings in beta thalassemia major in pediatric population in East Singbum. I have no financial interests. Globally, 19 million children are visually impaired, and an early screening is recommended for ocular complications for systemic diseases like thalassemia, very similar to ROP, as the prevalence of ocular findings in thalassemia ranges from 41 to 85%. So if you look at the ocular manifestations of thalassemia, it's almost 10% as a major cause in childhood visual impairment. And globally, as our Jharkhand is an endemic zone for this disease, where the prevalence of beta thalassemia in tribals in Jharkhand is about 7%, because this disease actually manifests early in the first 2 years of life, and a lot of clinical and psychological problems are associated, and both iron overload and iron chelation therapy, they both contribute to the ocular manifestation. The American Academy of Pediatrics has recommended an annual ophthalmic examination for children with thalassemia, starting from the diagnosis. Therefore, in order to avoid the progression to irreversible loss, we need to implement a multidisciplinary approach for this disease, collaborating the pediatrician, hematologists, and the ophthalmologist. So why the study? Now, as you know, the government has come up with a screening program for thalassemia, but it is optional, and therefore, this type of study can provide a national guideline for mandatory ophthalmic examination in thalassemia, and it also helps in understanding the clinical and psychological problems associated with thalassemia. So the aim of the study was primary objective was to identify and describe the ocular manifestations and their severity associated with thalassemia, and the secondary objective was to identify factors associated, socio-demographic factors, use of iron chelating agents, and number of transfusions for the ocular complications. So this was a hospital-based cross-sectional study, which was done on 84 children, 1 to 13 years, and a consecutive sampling was done for 200 registered cases in the Department of Pediatrics, MJ Medical College and Hospital, Jamshedpur. So all children of age 1 to 13 years who were diagnosed with beta thalassemia and whose parents gave consent, they were included, and children with other hemoglobinopathies and other congenital acquired comorbidity, they were excluded from the study. And a comprehensive ocular examination was done, serum ferritin was measured. Uncorrected and best-corrected visual acuity was done, and TBT was done to measure the dry eyes. This was these were the socio-demographic factors. The results, all the thalassemic patients, they were not asymptomatic, that they had various complaints like decreased vision, blurry vision, eye pain, discomfort, and other difficulties with night vision. In the visual acuity, it was decreased in 19% of patients, and ocular surface instability with dry eye disease and MGD was present in 38.1% of cases. In the slit lamp findings, we had conjunctival pallor anole associated with corneal arcus or iris hyperplasia. Some cases of VKC with pallor were seen, and slit lamp abnormality was present in almost 88.1% of cases. Fundus changes, we had angioid streaks, optic disc pallor, RP changes, some cases of CNVM, and the The compliance to chelation therapy was correlated with the visual acuity and ocular surface instability, and none of the correlations were significant, statistically significant. The compliance to, the correlation of serum ferritin with current chelation therapy was seen, and it was statistically significant. So in our study, we did not find any significant correlation between the ocular abnormality and serum ferritin levels. We did find a correlation, we did not find any positive correlation between RP changes and the serum ferritin levels. This was similar to the studies done by Jaffrey et al., where no statistical significant correlation was seen between the ocular abnormalities and serum ferritin levels. However, the number of blood transfusions were positively correlated with the serum ferritin. Similar studies like Rashid et al. Here also, children aged 12 to 17 years, where ocular manifestations of about 22.7 were seen. Here, male gender was a risk factor. The limitation of our study was it was a small sample size, and the diversity of patients require characteristics such as age and physical conditions or differences in the beta thalassemia treatment protocol in the past. They may confound some degree of results. Long-term RCTs are required for further. To conclude, recommendations, the study recommends ophthalmic screening to be integrated with the routine thalassemia follow-ups. Ocular changes are more common in thalassemia major, often asymptomatic until advanced stages. Screening and monitoring can prevent permanent vision impairment, and a multidisciplinary approach enhances outcome, ensuring both systemic and ocular health as addressed. Our study can propose evidence-based screening intervals, annual dilated examination. Thank you.
Thank you. I think thalassemia is more common in Punjab. You found so many cases there. I think that's a bit.
Sir, I am from Jharkhand, sir, and Jharkhand is an endemic zone for this disease.
Thalassemia.
Yes, sir.
Otherwise, you have studied in a very diverse way. There should have been some parameters which are specific to thalassemia. That probably would have been more specific and to the point. You have been very diffusely.
Sir,
you have studied so many things. I think.
Actually, sir, in our state, there has been no study in this concept regarding the ocular manifestations. And because the patients, they are directly coming in the pediatric department, they are not being referred to there. We were actually trying to make a regular protocol, a mandatory protocol for ophthalmic examination. Whenever the patient is coming to the pediatric department, they have to come to ophthal and then get the patient checked.
But we should be able to establish cause and effect relationship. They may just be having thalassemia, and the reason for say dry eye may be entirely different. So that cause and effect relationship.
Yes, for the studies, actually, we will be instituting.
You need to study more in a more specific way.
Yes, sir.
So, doctor, what are the limitations of your study?
So, first of all, ma'am, it was a very small, sample size was quite small, and we had methodology limitations also because we don't have an OCT at an institute. So that was one, and a lot of OCT and other MRI T2 need to be studied because iron overload that has to be excluded because chelation therapy in itself can also pose a lot of ocular toxicity. So the study was not able to differentiate between all those specific points. So further studies are required. I'll be doing that in future. Thank you so much. Sir.
Topical carbonic anhydrase inhibitors in treatment of juvenile X-linked retinoschisis, big data study.
Is Dr. Sindhuja there?
Yes.
Dr. Sindhuja.
Good morning, everyone. I'll be presenting a study on topical carbonic anhydrase inhibitors in treatment of juvenile X-linked retinoschisis, a big data study. So these are the abbreviations I've used. So, juvenile X-linked retinoschisis is a disease with an incidence between 1 in 5,000 and 1 in 25,000 males. It has a foveal schisis with splitting of the inner retinal layers, which is seen in 81 to 94% of the cases. So, Paola et al. Showed that visual acuity improved significantly after one cycle of carbonic anhydrase inhibitors with a sample size of 36, whereas Melanie et al. In their study of 18 eyes for a mean of 8.3 years showed that visual acuity improved, which was significant. This brings us to the need for a large study, thus enhancing our idea about the natural history of the disease. The purpose of our study was to report the efficacy of topical carbonic anhydrase inhibitors in treating juvenile X-linked retinoschisis, to look for the variation in visual acuity in logMAR units and variation of central subfield thickness in microns with topical carbonic anhydrase inhibitors. This is a retrospective review of records conducted in LV Prasad Eye Institute from a period of Jan 2014 to December 2024, which included 94 eyes of 50 patients. The demographics, symptoms, clinical features, and OCT findings were analyzed using appropriate statistics. The inclusion criteria and exclusion criteria were well defined, with a mean age at baseline which was 14.49 years, with an average follow-up of 45.44 months and a maximum follow-up of 96 months in 4 eyes. Total compliant patients were 86 and non-compliant being 8. Coming to the results, half of the visual acuity, half of the patients showed an improvement in visual acuity with a maximum of 63.8% improved by one line. 23.4% of the patients showed a decrease in vision with a maximum 40.9% dropped by one line. 25 patients had no change in vision. Out of the 22 patients with decreased vision, 4 actual had an increase in central subfield thickness, and the rest 18 had a decreased central subfield thickness in the last follow-up. This box plot representation shows improvement in visual acuity from around halfway point in the series of visits, which may be indicative of the effectiveness of the treatment being assessed. The consistency in the spread of measurements and the pattern of outliers could suggest a convergence in visual acuity measurements among the participants as the visit progresses. So this is a two-case honestly significant difference analysis test, which shows large estimate and wide confidence interval between 9th follow-up and baseline visual acuity, indicating a possible improvement. Coming to the central subfield thickness, this is a depiction of our patient showing reduced central subfield thickness in the follow-up. This box plot effectively provides a visual representation of the distribution of central subfield thickness measured across different time points, showing numerous outliers, particularly during the early visits, which decreased in later visits, suggesting a convergence in central subfield thickness measurements among the participants. So this two-case honestly significant difference test shows there was initial reduction in CST after commencing the carbonic anhydrase inhibitors, suggesting a successful initial intervention, with fluctuations in CST around visit 3 and 4 and a significant decrease in CST at visit 6 and 7, indicating treatment effectiveness, potentially indicating a therapeutic response, and a slightly increased CST in later visits, which might suggest stabilization. So beneficial effects of carbonic anhydrase inhibitors may be due to enhanced retinal adhesiveness to the retinal pigment epithelium, increased retinoschisin production, or removal of retinoschisin from the cystic spaces, which would not necessarily result in reduction in the CST. The presence of long-standing retinal cysts can ultimately be associated with development of atrophic macular lesions and further loss of visual acuity. So this study highlights that although structural changes occur with carbonic anhydrase inhibitor treatment, they may not directly translate into visual gains, thus showing the treatment is not only preventing the schisis in the macular area from increasing, but it may be help stabilizing the vision, if not improve the visual acuity. This is the first time a large population is being studied. So we will further require a longer follow-up, and the confounding factors may be the compliance of the patients and also the age at presentation, probably how many years the patients have been using carbonic anhydrase inhibitors from the age of presentation, which could also change the final outcome.
Was there a control group?
No, sir.
So then we don't know, is it because of carbonic anhydrase inhibitors, or it is just coincidental that possibility would be there? I think there should have been a control if you're doing a prospective study, in my mind.
This was a retrospective study, sir.
So it's a retrospective study.
Retrospective.
So you've taken data and you have seen.
Yes,
that.
sir.
Okay.
So how long was the treatment duration for the patients?
10-year study, ma'am, with an average of 45 months.
No, I'm asking for each patient per se, what was an average duration of the treatment when you were using these carbon anhydrase inhibitors?
So we have patients, the longest that we followed were 8 years, and then there are
They were
starting
there
from 2
for
years.
8 years
Yes.
for continuously on CI?
Yes, yes.
Normally we don't
no.
give for so long,
There'll
do
be
we?
compliance
Do we?
issues
Normally we
also.
don't give for so
Compliance
long.
issues were also there, ma'am. In between, there were people that stopped, and then they were restarted. So we called them at 6 months interval.
Actually, I am like, even Vinod was collecting some data from RPC, from AIMS Delhi, and I was along with him doing that study when I was in Delhi for some time. So I have seen in those occasions, you don't need to give carbon anhydrase so long, because once the macular subfoveal thickness, it stabilizes, those cysts and cyst cavities start reducing.
Yes.
Okay, you need not continue, because then the side effects of all these drops will start coming in. So I don't know, probably because your study was a retrospective study, probably you have not noted the period duration of treatment given to these children.
Okay, I'll
That should have been taken into consideration, because otherwise you can't give it for so long. The therapies are usually not given for so long.
And children particularly.
So in many the vision increased, in many the vision decreased. So is the treatment working? I mean, it's not like
in
everyone
20
increase and some increase more, some increase less, and some decrease also. So, and you're giving for 8 years, so is it really
So in
working?
22 patients, the vision decreased, but then what we found out was the CST actually did not increase. So that was, it could be due to macular atrophy, eventually that happened.
There are more things which can be documented in this,
Yeah.
and further deeper look is there.
Thank you. Thank you so much.
Now I invite Dr. Kuldeep Kumar Srivastav. He will be speaking on long-term results of combined trap and trap for primary congenital glaucoma.
A very good morning to all of you. I will be talking about results of combined trap for primary congenital glaucoma. I have no financial interest to disclose. Primary congenital glaucoma refers to glaucoma due to maldevelopment of trabecular meshwork. They are unassociated with major ocular abnormality, and incidence is 1 in 10,000 live births. They may present with the classical triad manifestation like epiphora, blepharospasm, and photophobia. However, the presence of megalocornea, cloudy cornea, or heavy stria and deep anterior chamber are sufficient to diagnose the disease. And if corneal diameter is more than 12 millimeter during infancy, it is highly suggestive of primary glaucoma. The treatment is always surgical. Goniotomy and trabeculotomy has the excellent result. But in developing country like ours, where children present very late with the hazy corneas, combined trabeculotomy and trabeculotomy may be the appropriate as a first-line approach. So the purpose was to assess the long-term result of combined trap for primary congenital glaucoma. It was a retrospective study where medical record of children who had undergone trap for primary congenital glaucoma between January 10 to December 18 were reviewed, and patients who had less than 5 years of follow-up were excluded from the study. This was a small surgical procedure. A radial incision on the blue-white junction and little oozing of blood are aqueous. Now you have to pass the trabeculotome around 60 degrees. If it is in correct plane, it is effortless and very smooth. And then you rotate. Now the aqueous is leaking. Similar procedure has to be performed in other side. Now anterior chamber entry was made with 2.8 keratome and with scleral punch that peripheral peripheral artery and 3 tenonylon suture, and conjunctiva was closed with 6A2 vicryl. The following surgery, the children were followed up at 1 day, 1 week, 1 month, 3 months, and 6 monthly thereafter. Post-op evaluation included blood characteristic, corneal diameter, axial length, IOP, central corneal thickness, and cup disc ratio. And the surgery was considered to be successful if post-op IOP was 21 or less, with or without medication, no increase in corneal diameter, and no increase in cup disc ratio. So there was 54 eyes of 32 patients during the study period who underwent CCT, but after applying the criteria of 5-year follow-up, only 35 eyes were available for analysis. 15 were male, 11 had bilateral disease, and consanguinity was present in 7 cases. The mean age at the time of surgery was 6.3 months, mean follow-up was 73 months, mean pre-op IOP was 28.4, mean post-op IOP at 1 year was 11.9, and 5 year was 12.4. This is the success rate where you can see that at 5 years, the complete success rate was 74.3%, and qualified plus complete success rate was 82.9%. This is the survival probability curve at 5 years with complete success, it is 0.04, and with complete plus qualified success, it is 0.083. There was a complication included cellular anterior chamber, 3 eyes, hyphimosis eyes, which resolved spontaneously without additional surgical intervention. There are no other complications. This is child operated at 2 months of age. This is operated at 1 month of age. This was operated at 3 month and 5-year-old picture. This is operated at 2 month, 1 year picture, and 5-year picture. Goniotomy and trabeculectomy are the first line of treatment for primary congenital glaucoma, but CCT may be more appropriate as first line treatment in children presenting with advanced disease and hazy cornea. CCT creates a dual exit pathway of aqueous humor through both Slim's canal and through guarded fistula of trabeculectomy. Several authors reported higher success rate of CCT than goniotomy and trabeculectomy alone. In our study, 5-year follow-up of complete success was 74.3%, and qualified for complete success at 5 years was 82.9%. Our results are similar to the other studies. In conclusion, combined trap-trap is a safe and effective procedure for treatment of primary congenital glaucoma. Thank you.
So what was new in this? Because this is known actually, so what was new in this?
It's not new, it's actually because congenital glaucoma is very rare, and an average center, they get hardly any patient. Like we get a OPD of 500-600 patients, and we get 5-6 cases in a year. So that's why we wanted to, like those who are doing like LVP, lot of cases. So I was just presenting a mid-level centers also, what can be a result like that.
And did you follow up them for their refractive errors and amblyopia? And did you any patients who required PK? And because sometimes the cornea doesn't clear up even after the IOP
Yeah,
control.
one patient required, the first patient, that's it. Which I shown
So that, okay.
Well, visual acuity details we don't have for most of these patients, and nobody had a
most
cataract.
of the patient, it's not, some are good, but I have not mentioned in this, but some has the poor actually, unilateral cases, they have amblyopia,
Yeah.
and we have been treating that.
So these cases, no more intervention is only one single surgery, no? That's
Yeah,
5
only
years.
single surgery, and that's the other which not success, we repeated the trap. That's
And after that, after repeating the trap, did the
no,
success
some
rate
cases
increase?
failed, and we went into the shunt.
And 5 years follow-up, I would say, was a long, very short period because once a glaucoma, it's a glaucoma for lifetime. It
Yeah,
doesn't
yeah.
go off. So it's
Yeah,
like,
so that's actually the survival falls at 10 years, it goes up to 60.
yeah.
so
So, and
we-
your failure rate increases with
Yeah, so we had
time.
only till this much data, so it's actually. For a mid-level hospital, it's very difficult to get the
Yeah,
large data in
So
these
many
cases.
I think.
Are lost to follow-up.
Yes.
Whether some
But you have not mentioned separately the repeat surgeries and all, na? You have taken it as a combined procedure in one go.
No, because those gone the unsuccessful. I was presenting the success rate. Those were unsuccessful.
Okay,
Those
okay.
patients went for the other surgeries.
So
So
how
those
much
were not
percentage?
taken into account.
Yeah, that's those were common failure. That's
How much percentage of these patients required topical anti-glaucoma medications?
it's around 20% cases.
And they were controlled with
Yeah, control width.
Qualified success is almost 100%.
No, no, not sir. At 5 year it is around 83% only. Yeah, it's not 100% that. Actually, first year it's around 91%, but at 5 year it goes to around 83%.
Thank you.
Thank you.
Thank you, Dr. Kuldeep. Now I invite Dr. Anita Sharma. She will be speaking on demographic and clinical profile of pediatric uveitis at Sri Care Center in North India. Dr. Anita Sharma. Next, I invite Dr. Aprajita Chaudhary. She will be speaking in advancement in biomarkers research for screening and diagnosis of ROP. Dr. Aprajita. Dr. Gulfashan. She will be speaking on analysis of clinical profile in aggressive ROP in tertiary care hospital. I don't know, sir.
Good morning, all. My topic is on analysis of clinical profile in AROP in tertiary care hospital. So we all know retinopathy of prematurity is a vasoproliferative retinopathy that affects the developing retinal blood vessels of the premature babies. It's a leading cause of avoidable blindness worldwide, with the prevalence being 18.4% in India. According to the recent ICMR classification, AROP can occur at any stage of classical ROP. Thus, it is defined as increased dilatation, tortuosity of vessels in all quadrants out of proportion to the peripheral. Retinopathy changes like flat fibrovascular proliferation, neovascularization, rapidly progressive course. The common age of presentation 32 to 34. I am the chief author, ma'am. She has a health issue. Yes. Yes, we had mailed and taken permission, ma'am.
Okay.
And the PPT also is uploaded in my AIOS account.
So you watch, Doctor?
Hemlata. The common age of presentation being 32 to 34 weeks after conception, with an incidence of around 2.5% in Western population, while in Indian population it is 10% to 12%. So the aim of the objective of our study to analyze these AROP babies and then associated risk factors. So coming to the result, among the 945 babies which we have screened, 84 babies were found to have ROP. Thus the incidence is around AROP 11.25%. The mean gestational age group is 29 weeks plus or minus 2 weeks. The lowest being 27 and the highest around 33 weeks, and the mean birth weight is 1.46 kg, lowest 0.9 and the highest is 1.7. The associated risk factors are respiratory distress syndrome, 45%, long NICU stay, 50% poor weight gain, 45% anemia, 36%, and very low birth weight and septicemia were seen in 22%. And the blood transfusion history is among 7 babies. The results, in the fundus picture, we can see there is a lot of zone 1 ROP in the right side with popcorn lesions and looping temporal slope, and the flat neovascularization peripheral avascular zone. And the associated maternal factors were elderly primary 40%, diabetic 26%, prolonged duration of labor 22%, and hypertension 13%. Zone 1 and Zone 2 ROP, when we saw, Zone 1 were 46 babies and Zone 2 38 babies. And the NVI, that is neovascularization, was seen around 30%. And 9%, that is 8 babies who didn't have good dilatation due to aggressive NVI, underwent anti-VEGF injection, that is ranibizumab. And 32 babies needed 2 to 3 sittings of laser. So these are the pictures where in the first we can see the hemorrhages with zone 2 posterior here, and these are multiple hemorrhages with shunting of vessels, peripheral looping, and this is zone 1 with extensive avascularity. And when we subcategorize the zone 1 and zone 2 babies, we saw like the low birth weight, NICU stay, neovascularization, temporal notch, and hemorrhages were more obvious seen in zone 1 babies. Zone 2 posterior, more of hemorrhages and vascular loops were noted. And here these are the peripheral vascular loops on the right side, and this post-laser well-stabilized fundus photograph. So coming to the discussion, in our study, the mean gestational age is 29 weeks with the birth weight of 1.7 kg in comparison with the Behra et al., where their 1.7 kg and the mean weeks is around 31 plus or minus 2 weeks. And the sepsis incidence is around 35%, and in our result it is around 22.7%. And AROP, when we saw zone 1 and zone 2 comparison, the vascular tortuosity, aggressive neovascularization and notching was obvious in zone 1, whereas vascular looping and junctional hemorrhages were seen in zone 2 posterior babies. The prolonged oxygen exposure is one of the risk factors, and in our study it is around 36%, whereas Jalali et al. It is 24%. In our study, most of the babies were managed with laser treatment, though many required, like around 23% required more than 1 sittings of laser, which is comparable with that of Ahan et al., where 33% of the babies need multiple sittings of laser. And especially when the babies are very sick, and we had to plan and zone 1 babies. In our study, only 9% underwent anti-veg injection because of poor dilatation and media hazy, which were followed with laser after 6 weeks. We also recommend zone 1, we can go for anti-veg injection. Thus, to conclude, with good NICU care, more babies being surviving, it's very important to not to miss the AROP babies and to treat the associated risk factors along with the eye. Thank you.
So you said that most of the babies underwent laser for aggressive ROP. Why not anti-VEGF, which is now most like a first-line treatment?
Sir, we don't have Avastin, sir. Like we are giving Razumab. And also many of the babies, we saw the recurrence is too high. Within 2 weeks, there will be recurrences. And ours is a government setup also. And another thing which I saw is conjunctivitis. So whenever suspected neonatal conjunctivitis, some babies we didn't prefer to do. So there I planned for more sittings of laser. And only when the requirement, we went for the injection, sir. Thank you, sir.
Now I invite Dr. Shivani Garg. Dr. Shivani. Dr. Fatima. Dr. Fatima will be speaking on long-term outcome of modified capsular tension ring fixation and IOL placement in ectopia lentis cases.
Very good morning to all. This is about long-term outcome of modified capsular tension ring fixation and IOL placement in ectopia lentis cases. As we know, ectopia lentis poses unique surgical challenges. Many a times, surgeons prefer to remove it and go for scleral fixation or iris fixation IOL. But the advantages of bag conservation using CONE ring is the lower rate of vitreous prolapse, and thereby the risk of retinal detachment is lower in these cases. Literature supports this. So the aim of the study is to analyze the long-term outcome of this bag conserving procedure in ectopia lentis patient. Ours is a prospective interventional case series where the less than 16 years of age children were included, and those children who had prior intraocular surgery, ocular trauma and comorbidities were excluded. And the data was analyzed on the basis of IOL centration, best corrected visual acuity and complication. This is the surgical procedure where clear corneal entry is made and rhexis is being done using micro forceps. And the Hoffman pocket is made from the corneal side, and the edges of the pocket is marked. And using a double arm 9O proline suture and introducing a 26 gauge cannula from the through the pocket, one arm of the needle is taken out and the other arm is passed through the eyelet of the CONE ring, and again then the second arm is passed. Before that, the wound is extended a bit more to allow a comfortable introduction of CONE eyelet, and the CONE ring is placed in the bag, and suture knots are retrieved from the pocket, and suture ends tied together and knot is buried into the pocket, and IOL is placed in the bag. So it was 35 eyes of 21 patients, and our mean age is 8.7 years, ranging from 4 to 16 years. Majority were male patients and left eye, and it was most of the cases were bilateral. Our mean IOL power was 21 diopter IOL, and the CONE type was either 10L, 10R or 11R. And the suture, it was mostly 9O proline suture. And temporal subluxation was the most common subluxation we observed. And mean axial length was 23.5 mm, and average follow-up is 2 years, and ranging from 8 to 53 months, it's nearly 4 to 5 years. IOL centration is observed in most of the cases. And best corrected, if we look at the uncorrected visual acuity and best corrected visual acuity, there is a little bit difference. This is due to purposeful undercorrection considering myopic shift in younger children. And when we look at the Snellen's acuity, 94% showed visual acuity more than 6/12. Remaining 6%, this is due to amblyopia developed due to late presentation and late intervention. And there was 2 eyes, those showed minimal decentration, but not yet required surgical intervention. There was no vision-threatening complication. And posterior capsular opacification was observed in 13 eyes, 37.1%. When the mean duration was 2 years post-surgery. When we look at the other studies using CONE ring, there were studies that included both adult and pediatric patients. So when we consider the studies with only pediatric patients, here is an interesting study by Chen et al. Where they have done 174 eyes, all are Marfan children. And the interesting observation is there were only 2 eyes showed retinal detachment out of 174 eyes. They claim that is due to minimal disruption of vitreous basement by following the back conserving procedure. So when we compare our study with other similar age group studies, the minimal decentration, the number is similar, and this PCO incidence. Here, if we look at the Lia K et al., the interesting observation is they have done prophylactic eye capsulotomy in post-surgery. That denotes the safety of applying eye capsulotomy in these cases. This is a study where 37 eyes of 22 children was done by Tina et al. Here the difference is the age group was very less, 52 months mean age. So they end up with a high number of, out of 37 eyes, 26 eyes had undergone secondary surgery for visual axis opacification. But our age group is little elder, so none of our cases required surgical intervention. And the mean duration of 2 years post-surgery to develop visual axis opacification allowed our youngest child 4 years to become 6 years and cooperate for eye capsulotomy procedure. So the long-term outcome of CONE ring fixation shows good outcome in visual acuity and low complication rate.
2 things I would like to
Thank
ask. Were there any cataractous lenses in your cases?
No,
They
no.
were all clear lenses.
Yeah, all
so
are clear.
anyway, the chances of posterior capsular opacification reduces markedly in that case. So that is one reason. Secondly, you said your age group was elder. So it was above 6 years.
Minimum age is 4 years.
In your studies?
Yeah.
Okay, so how many children were there above, like less than 8
Very, very less. Only it ranges up to 4 to 16 years.
No, but how many were there less than 8 years? Because you don't need to undercorrect them, as you said, no, because your uncorrected visual acuity was less in a lot of them.
Yeah. Only.
I mean, because of the cylindrical power which is induced as such because of the incisions itself, the surgically induced astigmatism, rather than actually the undercorrection which was required. Because normally you don't need to undercorrect after the age of 6 years.
Yes. We undercorrect a bit 0.5 diopter up to 10 years of age.
How many were Marfans out of these? Because you didn't talk about etiology of
yes, sir. Actually, genetically proven Marfan we have not come. Till now, we are practicing for Marfans. We don't do such intervention. But clear cut that patients that fit in that Gens criteria, we have not seen Marfan. It's more all are isolated ectopia lentis, and some are familial isolated ectopia lentis.
But sporadic ectopia is not very common actually.
Yes, sir. We are analyzing the data. We want to.
Or other conditions.
Yes, sir. We are doing.
Yeah, particularly those conditions I think should be ruled out because
yeah.
it's important. We have systemic issues which can be
yes, sir.
long-term issues.
We are doing echocardiogram for every patient, and we are looking for that aortic root Z scoring to fit in the criteria of Marfan. But sometimes patients present with that Marfanoid habitus features, but they are not exactly fitting into that aortic root criteria, echocardiogram criteria, and genetic criteria.
You have taken into account ectopia lentis due to trauma also?
No, in this series it didn't. There was no trauma.
And
case.
how long was your follow-up? How long?
Maximum is 53 months, 4.5 years.
Thank you.
Thank you.
Dr. Manu Sharma is there. Dr. Manu Sharma will be speaking on immediate sequential bilateral vitreoretinal surgery for management of ROP.
Good morning, everyone. I'm feeling grateful for this opportunity. My topic is immediate sequential bilateral vitreoretinal surgery for management of retinopathy of prematurity. Immediate sequential bilateral vitreoretinal surgery is defined as vitreoretinal surgery in both eyes during the same anesthesia session. It is an enormous need in the era of more advancement in neonatal care, more of surviving of premature babies, and lead to more incidence of retinopathy of prematurity. Although there is an awareness of ROP, but still it's lacking, which lead to more of ROP cases in stage 4 and stage 5 presenting to us, which are not manageable with anti-VEGFs and lasers alone. So here comes the need of bilateral or need of surgery in these patients. So bilateral simultaneous, because it is a bilateral disease, symmetrical disease, and progressive. And there is a risk of anesthesia, and these babies are small, sick, premature, also associated with comorbidities like RDS, BPD. So, and the risk of re-anesthesia for the second surgery is difficult and undesirable. So it also leads to delayed surgical intervention and the poor outcome, as disease is bilateral symmetrical and it is progressive. And there are financial challenges also. So single session surgery can address all these issues and lead to good outcome. So our purpose is to study the efficacy, safety, anatomical outcome of bilateral sequential vitreoretinal surgery in advanced ROP. So it's a retrospective interventional study conducted in tertiary eye care center. We include the cases of 4A, 4B, and the 5 open funnel ROP. We exclude the closed funnel RD patients and 5C with anterior segment malformations. The electronic medical record system was used to get the data, and the surgeries were performed by the two surgeons, and the maximum follow-up 3 months were included. So we found 55 eyes of 28 babies with mean birth weight of 1,188 grams with mean period of gestation of 30 weeks. 68 were males, 32 were females. At the presentation, the stage 4A was seen in 16 eyes, stage 4 in 36 eyes, and stage 5A in 2 eyes. One had vitreous hemorrhage. So lens-sparing vitrectomy was done in 50 eyes, and lensectomy vitrectomy was done in 5 eyes. Laser photocoagulation was done in all eyes except stage 5, and preoperative ranibizumab biosimilar was given in 21 eyes. So outcome, we defined anatomical success as complete success when the fovea was attached and there was no peripheral traction. And in incomplete success, we labeled incomplete success as when the fovea was attached and there is only mild peripheral traction, but no traction at the fovea and the macula. And failure, we defined when there is some traction at the macular area or fovea. We have low threshold for the failure. I think we kept the low threshold for the failure. We even labeled when there is some traction at the macular area, we labeled it as a failure. In ocular complication, we found hypotony in 2 eyes, choroidals in 1, loose blood in 7 eyes, and no endophthalmitis was noticed in any eyes, which was the main concern in bilateral vitreoretinal surgery. In systemic complications, only 2 babies had anesthesia-related complications, and 1 baby had, we have to abandon the second eye surgery because it was not, the baby was not maintaining saturation, and 1 baby had apnea, but it was after the surgery, and he was kept under monitoring and recovered. This outcome, we found a good anatomical outcome. The fovea is attached and there is no residual traction. So it is a blinding disease of low birth weight babies. Timely management lead to better anatomical and functional outcome. Risk of GA-related morbidity is high, but with a good anesthesia team, it can be manageable. And although there is a risk of endophthalmitis, but it can be addressed because during intraoperative period, we manage the both eyes
as a single individual eyes. There is a redraping and trolley is remade and the surgical team scrub and every precaution is taken during surgery and there is no risk of endophthalmitis, or we have not reported a single case of endophthalmitis in our series. Although there are ethical issues which can be addressed and the patient, we can minimize the GA-related morbidity by taking extra precautions. So to conclude, BVS is a safe and feasible option with good anesthetic care. And as the disease is bilateral, symmetrical, and progressive, so it can be a feasible option. And well-informed consent mentioning risk of anesthesia and bilateral endophthalmitis must be taken to avoid medical legal consequences. Thank you.
So you wanted to do bilateral cases. So the idea was basically that you want to deal with both the eyes very quickly.
Yes.
In the same sitting.
Yes.
So why did you include stage 5 ROP cases in this? I mean, there's no urgency.
So stage 5 cases, only the stage 5A cases, which we thought they can be managed when the funnel is open. We can approach.
So the early stage 5.
Yes, sir, early stage 5. Yes, sir.
But I think it's unethical doing sequential surgery, both eyes together, same sitting.
No, sir, I don't think so. It is unethical. If patient attendants give consent and we have a good anesthesia backup.
Patients will give consent, patients, they are in that kind of space, they would give consent.
Sir, I think.
That just because consent is there, we must go ahead with everything.
No, sir. I think the only concern we have is the risk of endophthalmitis, which can be addressed because we prepare both eyes as two separate cases. First, we do the one eye surgery, then even we ask for 2 packs from the patient. Under GSSK scheme, we have 2 packs, 27 or 25 gauge, whatever. So everything is prepared as a separate case for both eyes.
So despite all precautions,
Yes,
you
sir.
are saying there can be endophthalmitis. That possibility is there. Nobody can rule
Yes,
out
sir,
the
there
possibility
is
of endophthalmitis.
yeah, but
So I think that bilateral surgery in a young child, I mean, I have my concern.
sir, there are only yes, sir.
It is good that you have presented this in the conference, but it is practical advice not to do it practically, because even if a single case is there in lifetime, nobody is going to spare you.
Yeah.
What would be the socioeconomic status of the patients? That would also really make a lot of difference on the post-op care that is offered by the parents. Once you've done the surgery, you've taken all precautions during the surgery, but what about after?
What is your take on this, since we're having a discussion on this ethical issue? Because, sir, in pediatric cataracts also, outside India, everybody is doing bilateral sequential.
Yeah.
Yes, ma'am.
The only thing is, only common aspect of doing a bilateral sequential is the OT setup. Rest of the things you have taken care of.
So we also do bilateral. We also do bilateral simultaneous because stage 4 is rapidly progressing, and the children are very sick and are very high risk for GA. So doing simultaneous is recommended in stage 4A, where it's because child might become very sick after that, and the second eye might go blind. So earlier we also used to do sequential, but now we also do bilateral simultaneous in stage 4. It's just a very small window, and the child might get very bad in a 1 week time if you delay the surgery. And
If we
GA
delay,
sessions.
that lead to blindness in the other eye because.
You should have clarity about the indications, I think. That's
Yes.
more important.
Yeah.
Thank you.
Do you consider this factor, like do you check the socioeconomic status of the?
No, we don't.
Ma'am, they are very. Ma'am, we prescribe both eyes different drops and everything different.
Yeah, actually the
different
take is
set of
that
drops
we
for
have
both
to see
eyes.
the pros and cons. Where if you are going to towards the worsening of the disease in few days, means we can go ahead.
Yes,
na?
ma'am.
Otherwise, because we can take precaution per-operatively, but post-operatively, if the parents they don't take care, the child will go blind.
Actually, we have population which is quite poor. They are
Yeah,
not able to
the
access
post-op
the
care is also very
follow-up
important.
May not be there. So I think we shouldn't compare everything with what's happening in West. It's a different kind of scenario with us. So somebody comes to RP center, he may not be able to come back. They go back to 500 kilometers. And they're not able to return. I think that aspect is important to keep in mind in our setting.
Thank you. Now I invite Dr. Lubhavni Diwan. She will be speaking on pediatric third nerve palsy, clinical and demographic profile of patients at tertiary eye care center. Is Dr. Silpa there?
good morning, everybody. I'll be talking about isolated pediatric third nerve palsy in children, the clinical, etiological, and the neuroimaging profile. I have no financial disclosures and no conflicts of interest. So, isolated third nerve palsy in children is rare, and about half of these cases are reported to be congenital, with another half being secondary to trauma, neoplasms, infections, and so on. And congenital cases may present with complex features since they represent a part of the spectrum of cranial degeneration disorders, and they may be difficult to differentiate from other acquired causes, some of which can be life-threatening as well. And therefore, neuroimaging is considered mandatory in all these cases. The lacunae in this field include the relatively smaller case series in existing literature and the low yield of neuroimaging with a large proportion of undiagnosed cases and a poor distinction between congenital and acquired causes. There is also an absence of a defined protocol for ordering neuroimaging in these cases. So the purpose of the current study was to analyze the clinical features, the neuroimaging findings, and the etiological profile of a large number of isolated pediatric third nerve palsy cases presenting to our tertiary care referral center, and to come up with guidelines for defining the neuroimaging requisition in these cases. This was a retrospective review of the electronic medical records carried out at Jasti V. Ramanamma Children's Eye Care Center, L.V. Prasad Eye Institute, Hyderabad, spanning a duration of 8 years, wherein we included all patients under the age of 16 years with a diagnosis of congenital or acquired third nerve palsy, and excluded those with an alternate final diagnosis and those with coexisting other motor cranial nerve palsies. So these were the results. 131 case files met the inclusion and the exclusion criteria, of which 64 were congenital and 67 acquired, with the congenital cases presenting on an average 2 years prior to the acquired onset cases and tending to have a worse logmar visual acuity, which can possibly be attributed to the dense amblyopia seen in these eyes. While the deviation and the motility limitation were not seen to be significantly different between the two cases, there were some differences with regards to the severity of the ptosis, the presence of Marcus gun jaw winking phenomenon, and the prevalence of aberrant regeneration at the presentation and the final follow-up. Also, interestingly, there was a progression noted in 14% of congenital cases, though this was significantly more in the acquired onset cases. So with regards to pupillary involvement, this was seen in 40% of congenital cases versus almost twice the number in the acquired cases, and most of these were in the form of a mid-dilated, poorly constricting pupil. Interestingly, a meiotic pupil was also noted in about 8% of congenital cases and none in the acquired group, and all of these 8% cases had a hypoplastic or an aplastic third nerve on the neuroimaging. These are the neuroimaging results of the congenital cases. A high-resolution Fiesta scan, that is a fast imaging employing steady-state acquisition scan of the third nerve, showed an aplastic or a hypoplastic third nerve in 54%, whereas other associated abnormalities such as a faces syndrome or corpus callosal agenesis was seen in additional 12%, with the overall yield being 66%. The orbital imaging showed muscle thinning supplied by the third nerve in variable distributions. And with regards to acquired cases, the largest proportion were seen to be post-traumatic, followed by inflammatory and compressive lesions. 12% of the cases did not yield any positive findings on the imaging, where another 12% showed an isolated schwannoma or neuroma of the third cranial nerve. Now, this was an important cause that was seen in our series. These cases were picked up as an isolated tiny nodular or fusiform enlargement of the third cranial nerve, as seen in this image here, which shows intense post-contrast enhancement and a T2 hyperintensity. So this is one prototype case showing progressive exotropia and ptosis, which was initially suspected to be a congenital third nerve palsy because of the muscle thinning seen on the orbital imaging, and the Fiesta scan revealed the schwannoma. So in summary, we saw a slightly higher proportion of acquired than congenital cases, which has also been reported previously. Pupillary involvement was seen more often in acquired than in congenital cases, which had a small proportion of a meiotic pupil as opposed to a mydriatic pupil. The yield of neuroimaging was seen to be higher than what has been previously reported using Fiesta sequence imaging for the oculomotor nerves. So these are the key takeaways from the study, and we propose a uniform imaging protocol using high-resolution MR imaging of the brain and orbit, along with cranial nerve imaging using Fiesta sequence with thin sections as a mandatory requirement in all cases of isolated pediatric third nerve palsy. Thank you for the patient listening.
Thank you. Do you recommend that all these congenital cases should go neuroimaging?
Yes, that is what we have understood from our experience, doctor, because the congenital and acquired cases can have an overlap in sense of the clinical features. There can be progression seen.
Sorry for interrupting. See, the problem is what is congenital and what is acquired. What happens, suppose a child who is 2-year-old has a palsy which is actually acquired, and he comes at age of 4 years. This may be classed as congenital. That difficulty is also there. So until you have taken cases which were congenitally present at birth, or say a month, 2-3 months or 6 months, that risk is there that some of the acquired ones may pass on as congenital.
Yes.
And
So
when you're talking about hypoplasia and aplasia, what was the size of the third nerve on MRI? Did they indicate what was the thickness of the third nerve as compared to the other eye?
So the thickness was indicated in a few scans, not in all, but the aplastic or a non-visualized cisternal segment was more often reported in the ones that cited an aplasia, complete aplasia. For the hypoplastic ones, we do not have the exact measurements for all the cases.
Complete aplasia of the third nerve would be very rare, you know. Some of these which have superior division issues, they go in for CFUM, you know, type 1, type 2. They end up more as CCDDs rather as this. And then the aberrant innervation part you were saying, if it is in congenital cases, if there is even pupil is involved, so this may not always indicate something like compressive lesion as it is in acquired. So I think that has to be kept in mind.
Exactly. So that is the reason why we said that acquired, there is an overlap between the congenital acquired cases. So to differentiate, the neuroimaging becomes very important, because some of these causes can require neurosurgical intervention and radiofrequency ablation and all those things.
Yeah, I think one has to be a bit judicious, because the imaging everyone is also not easy. Some follow-up that will also tell you what is happening, and if there is aberrant innervation, that usually points out to some kind of compressive lesion, you know. So if there is an aberrant, like you had schwannomas, they are very important.
Yes, slowly progressive lesions can also end up with aberrant
an
regeneration.
isolated third nerve. So you have not mentioned these were isolated third nerves.
These were isolated. All of these were
isolated.
isolated.
That is important, because if it is non-isolated, everything becomes very different.
Yes.
Thank you for
Just one thing, you said, no, there were some cases where you did not find any findings on the MRI. So in those cases, as you rightly pointed in the last slide, MRI should be done, because I have recently reported a case where there is a neurovascular conflict causing isolated third nerve palsy, the congenital palsy.
Yes.
So it can happen. So you should, where you do not find anything else, go for an MRI.
No, imaging in all the cases may not.
No, sir, so where you do not find anything.
If there is a reason for suspecting something, then you should do. But otherwise, I think every child to be imaged also is a bit of, in our settings, if you see from Western point of view, every acquired 6 nerve they may image. We say that wait for some time, 3 months, and then take a call on it. Because if it is due to diabetes, let's say, it is going to recover. So subject everyone for MRI is also a bit, loading the MRI also, you know, in our country. So one has to be judicious a bit. Thank you. Thank you so much.
Thank you, Dr. Lubhavni. Is Dr. Silpa there? Now I invite Dr. Suresh Kumar Pandey. He will be speaking on evaluating simultaneous bilateral cataract surgery and IOL implantation in infants, a 10 years review.
Very good morning, respected chairpersons and members on dais. I'm going to talk about our study evaluating the bilateral cataract surgery and IOL implantation in infants, a 10 years review. As we all know that the childhood blindness remains one of the most common cause which need to be addressed very urgently. Globally, 2 million children are blind, and out of those, 2 lakhs are because of pediatric cataract. And pediatric cataract remains one of the most important preventable cause of blindness in India and globally. And in India, many times, most of the children are delayed to come to the doctor for treatment because of many reasons. And if we talk about the visually significant cataract, in our study, more than 3 millimeter central lenticular opacity, which was considered visually significant, was taken for surgery. And IOL implantation in infants remains debatable. We did the thorough evaluation and systemic evaluation, pediatrician consultation, anesthetic consultation, and then we took 30 cases which were reviewed in a retrospective study who underwent cataract surgery and lens implantation, bilateral infantile cataract surgery and lens implantation. And as very nicely mentioned in the previous talk, that this is very important and ethical and sensitive review, and the surgeon should be very careful in doing both cases simultaneously because of high risk of endophthalmitis. We used all the precautions, separate trolley, surgical instruments were used, each eye undergoing separate, cleaning and draping. And the lens implantation together with primary posterior capsular primary posterior capsulectomy and antivitrectomy was done to prevent the visual axis opacification. IOL power calculation remains a challenge in such cases, so we used the undercorrection to adjust the power, and 20% undercorrection was done. And post-op follow-up was included refraction, IOP measurement, and amblyopathy therapy. And this is the surgical video showing the bilateral cataract surgery and lens implantation in infant, 5-month-old infant. And in 4 cases, we used Zepto precision nanopulse technology to achieve the anterior capsular axis. And this instrument is very good. However, we should be careful in using such instrument in infants because of the shallow anterior chamber. In this particular case, we used dispersive OVD viscoat, and this is lens implantation done, and this was followed by the primary posterior capsulectomy and antivitrectomy with injection of intracameral triamcinolone acetonide to prevent inflammation and intracameral moxifloxacin to prevent the inflammation. All sutures, all incisions were sutured carefully. Every case underwent the post-op evaluation and examination under anesthesia. So, in all surgery proceeded without any significant intra or post-op complications, including endophthalmitis. The visual acuity improved in all cases. In such cases, some cases, amblyopia remains one of the most challenging aspects. Amblyopia therapy, managed with amblyopia therapy. And if you talk about the age, our age group was from 18 months, and the simultaneous bilateral cataract surgery in infants improved the visual acuity, and there was myopic shift was noticed, and we noticed the visual opacification in 6 eyes, which was managed with the posterior capsulectomy. In 4 eyes, we noticed the post-op spike, which was managed with the anti-glaucoma medications. So, simultaneous bilateral infantile cataract surgery is debatable now. There are some advantages are there, like you can get the cost reduction, and you can address the case at the same time. But however, it should be done very carefully because we are living in the era of litigation, and any case which can any complication can lead us into trouble. So this is there are some reports published showing the simultaneous bilateral cataract surgery in infants, and in our series, we were very selective. We excluded all the microphthalmos cases, and that's why the results were good. Thank you so much for your kind attention.
Thank you, Dr. Suresh. Very nice presentation, and you are a very confident surgeon. So I think for average surgeon, bilateral surgery would be a bit difficult prospect. What was the age group? You were saying infants, and these were
till 18 months.
Till 18 months. And how much was the follow-up?
Follow-up was, sir, follow-up range from, for maximum follow-up was 10 years, and it was 1 year to 10 years.
1 year to 10 years.
Yes, sir.
And some of these cases could be asymmetrical. So
Yes,
maybe they have had more cataract in one eye, and so the amblyopia will be more in the eye which is having more cataract.
Yes.
So that, I think, aspect has to be, maybe if you operate one eye and other eye later, some amblyopia therapy can be done because the vision has improved in that eye. So that those things are...
In most of cases, sir, cataract were like, total cataract.
Symmetrical total cataract.
Yes. Thank you, sir.
And thank you.
So with that, we close this session, and I request all the chairpersons to come for a group photograph, and after that, all the speakers with a group photograph. कलेक्ट कौन कर रहा है? अरे यार तुम बड़े ढीले हो ऑडियो विजुअल किसके कनेक्ट कर रहे हो? कौन सी कंपनी के हो? ये और ये वाला
इसको ये भी जवाब देने में टाइम लगा।
तो क्यों दूसरों को बुलाओ ना, पैसे कम मिलेंगे क्या?
लो, अरे जोड़ दिया ना। हो गया? डॉक्टर पांडे सबसे ऊपर जो था, करना।
अच्छा ये कर रहे हैं।
आ जाओ।
सारे स्पीकर आ जाए, सारे स्पीकर आ जाए।
सारे